Hi, I'm Dr. Dan Cox, a professor of counseling psychology at the University of British Columbia, and welcome to Psychotherapy and Applied Psychology, where we explore practical insights with leading experts. Today, I am thrilled to welcome back Dr. Bob Krueger, one of the world's authorities on psychiatric diagnoses. In talking with my guest, a cutting edge researcher that is at the frontier of using mathematics and other methods for understanding psychiatric diagnoses, I was struck by how much he considers the clinician's and patient's experience in his work. In this conversation, you'll learn about how personality is integrated into the HiTOP model and what using the HiTOP model of psychopathology in clinical practice looks like. And please feel free to leave a comment below. And if you enjoy this conversation, it'd be appreciated if you hit the like button and subscribe to the channel. This episode begins with my guest talking about how personality is embedded within the HiTOP model. Let's jump in.
But psychopathology is taking place in the context of a person's basic dispositional, nature and setup. So that's, I think, where the clinical utility comes in for me. I have a hard time thinking about a case without understanding the personality of the case, if that makes sense, right? Like, who is this person? What are their basic dispositional features? And it's always the case with psychopathology. I think that, that's the way in which people experience problems in the context of what they're basically like as they encounter the world, right? It's their personality that's intersecting with the things that happen to them, or the things that they do to the world, right? Like, are being driven by their dispositions. And again, that's not to say that personality is fixed and unchanging and totally 100% heritable, or whatever you might say, right? Like, that these things are sort of, it's not possible to work with personality clinically. I think that's another misunderstanding that people often have. So I just want to kind of call that out, right? I think personality is kind of the key construct in clinical case conceptualization. That's part of the reason HiTOP is organized the way it is. Personality is relevant beyond the personality disorders, which is a whole separate matter. And if you get to know the personality of the person, you have a much better handle on who am I dealing with here. So yeah, I can try to make that as vivid as I can, right? Like using a specific kind of case example that I often use in workshops, right? You encounter two patients, both clearly meet criteria for major depressive episode, right? And that's the presenting complaint, right? They're coming in because they're depressed. They're having problems with, sleeping and eating and engagement and being able to go to work or school, right? Kind of classic depressive presentations. And that's why they're there. Imagine one of those people is like the sweetest person you'd ever meet, right? So they lack all those antagonistic features. One of them, and they have similar levels of depression, is really antagonistic, difficult to get along with, oftentimes, finds themselves at odds with other people. I mean, you can say well, they both have depression, so I'm going to do CBT for depression. But that's going to go really differently for those two cases. I mean, this is an example. There was a time when I was seeing two people who were like this, and that is part of how the light bulb came on for me. It's like, oh, right, with the one guy that I was seeing, very, very kind, very sweet, appreciated all my efforts. I got some medical referral things to happen that were super helpful to him. Right, just everything I did was very much appreciated. He would do his homework, right, and that was great, right, because you had and of course the essence of effective psychotherapy, as I'm sure we would agree, is the relationship, right? So we built a strong relationship, and it was straightforward to do it. Okay, and then the other guy, it doesn't matter. Maybe you should try some homework. I don't like this homework. This is stupid. This is a waste of time. Right? Nothing's going to help me. Life is hopeless. Right? And I don't really like you. I've never really liked any of my therapists. You guys are just in this for the money, after all. That's a very different presentation. Right? That's a very different kind of person to try to work with, because you've got to work around or work with that basic hostility, right? That essential antagonism that the person carries with them in their approach to the world, versus the other person who's, lacking those qualities. If anything, has the opposite quality of being very agreeable, easy to get along with, very interested in smoothing over, social circumstances. So maybe that example helps, right? Because I once you start to see that stuff clinically, it becomes clear to me that you've got to understand personality, because it's the context in which psychopathology is occurring. Both of those people were very depressed and had a clear and similar presenting complaint having to do with how depression was affecting their ability to function and some clear treatment goals surrounding that. But their different personalities affected how you had to proceed. Because you're not just going to get somebody who's antagonistic to do homework or whatever, or to engage with, the treatment protocol. Even if that protocol is well laid out, it's going to be a much bigger challenge. So that's the essence of what I want to convey about, like the dimensionality of these things, and also the kind of the multidimensionality. Like, you need a personality profile, and why I think it's very clinically useful to understand the way personality affects presentations, and then be able to like pivot and modify your approach as a therapist to recognize, those kinds of personality differences.
So in the HiTOP model, personality is brought into the, I don't know if even diagnosis is the right word, but it's brought in, and then in the system, the words, there are traits and there are components, right? That is sort of the two terms that are used in the HiTOP framework to talk about sort of what we would traditionally think of as symptoms, I guess, and more personality.
Yeah, and so I think that is that setup is meant to recognize that some things are more like symptoms in that they're kind of focal behavioral tendencies that might come and go more readily. And some things are more like traits in that they're more like dispositional tendencies that kind of carry more across time and circumstance. So something like self-harm, right, or specific kinds of eating behaviors, specific kinds of sexual problems, right? These are more like behavioral clusters. And certain other kinds of things, like the aforementioned examples of disinhibition and antagonism, are more like dispositional things, personality matters. And then you kind of need both concepts to make sense of psychopathology, because traditionally psychopathological concepts contain elements of both, right? They contain things that are more like dispositions, traits and tendencies, and they contain things that are more like behavioral problems of a more focal nature. So to make that all work, right, you kind of need both things within the model. And I think that's how HiTOP tries to handle that fact. Like, that some things that are part of psychopathology are more like behavioral clusters, right, of specific kind of problem behaviors that a clinician might be presented with. And some things are more like dispositional tendencies. It's not to say that this distinction isn't fuzzy, right? There are overlapping aspects to this. And in fact, some HiTOP colleagues have argued that to the extent that the behavior persists, then it's a trait, right? Like, that's one way to handle that putative distinction. Whereas to the extent that the behavior is time varying, it's less trait-like. But, practically speaking, as a clinician, you got to pay attention to both those things, I think. Because sometimes, right, the presenting complaint is really a very focal behavioral problem. And then that's what you need to deal with primarily. And that might be a situation where personality might interfere, but might be less centrally relevant than a much more, well, frankly, like behavioral kind of perspective. Like, what's the problem behavior? Let's do a functional analysis of what's supporting this problem behavior and try to intervene on that level. Like, sometimes I think that can be fairly effective, and you don't need to bring in a lot of broader dispositional stuff. But even there, is the person going to cooperate with the behavioral intervention? Well, again, like, I guess even there, personality is going to come into play. Right? Like, to get somebody to do something, right? Exposure and response prevention or something like this or whatever, like, they got to cooperate. The classic axiom, right? Like, they're not going to change without, like, being willing to change or being willing to engage with the therapy. Like, getting people engaged is a big part of the whole battle, right, in effective psychotherapy. Is they have to connect with you, you have to establish a good working relationship, and then they have to engage. So I guess even for focal behavioral problems a person might come in with, like a sexual complaint or something that's very behavioral. I'm just trying to think of examples of like there's a really, really specific behavior thing I want to change about myself. Like it's still in the context of like who is this person and how easily can I connect with them, I suppose, right? I guess
So do
that's
you
my point. Like you kind of need both to get back to kind of I think what you were asking me about, which is like HiTOP kind of has both these behavioral syndrome type elements and these kind of dispositional trait type elements. I think that's because psychopathology, as it presents in the clinic, has both elements.
so do you think we should retain or get rid of the distinction between the personality disorders and the disorders we're talking about now?
Yeah, that's a really great question. It's been a question of great interest recently um, in the literature. And I think it requires some recasting, maybe, of what we mean by personality disorder. So, like, there's all these constructs floating around with this psychopathology. We've talked a lot about personality today. Now you've introduced personality disorder, right, which adds the word disorder to the concept of personality. And I think if you look at kind of like the DSM and ask, well, what makes these syndromes personality disorders as opposed to mental disorders? It used to be that was on axis 1 and axis 2. DSM-5 did away with the multi-axial thing, but traditionally people I think still talk about axis 1 and axis 2 disorders as the mental disorders and personality disorders, right? When you look at like what's in that personality disorders chapter, what kind of features of presentations are described there that aren't described in the other parts as much, it's interpersonal stuff, right? So when that kind of like happens clinically too, when people say like this person has a personality kind of flavor, there's probably a personality disorder present. They mean there's interpersonal stuff that's present, right? That isn't so much present with people who don't have a personality disorder. So some colleagues of mine, like Aidan Wright and his, colleagues have proposed that you could think about these as the interpersonal disorders rather than the personality disorders, because personality is relevant to all of psychopathology. But the things that have traditionally been called personality disorders are really more like interpersonal kinds of problems. So I think that's a compelling way of recasting what this is about. And then what gets tricky is like, well, interpersonal stuff is present in a lot of psychopathology. So is the distinction even really all that relevant? And I guess I come back to certain concepts are hard to get rid of. Like, I mean, I'm the editor of the Journal of Personality Disorders. I guess I have some endorsement of the concept of personality disorders by virtue of this. But of course, this is an enterprise I inherited from people who came before me. So, like, am I going to, like, have some campaign to eliminate the concept of personality disorders? That's not going to go particularly well because it's a concept that's been there for a long time. But I think thinking about what we meant by personality disorders might have been more like presentations where interpersonal difficulties are really at the fore, right, and are really relevant to the case presentation. That might be a better way of thinking about what did we mean by personality disorders. Because, again, personality is relevant to all of psychopathology. So maybe that helps to answer your question, which is like, should we get rid of the distinction? I think we should recognize that personality, right, like is at the core of a lot of psychopathology. That's going to be helpful clinically to get that idea across. And then ask, are interpersonal factors a key aspect of the presentation? Because then that might call for the kinds of approaches that have traditionally been classified under the personality disorders.
The way that you're describing it, it almost sounds like another dimension that like we would have interpersonal factors or interpersonal dysfunction or whatever it is as a separate axis.
That's kind of that's how the alternative model of personality disorders, which we talked about in our previous conversation, kind of handles that, right? In the AMPD, there's personality variation, which is criterion B in that model, and there's interpersonal difficulties, which also have self manifestations, right? So these things are kind of conjoined psychologically. Like people who have difficulty conceptualizing other people in coherent and adaptive ways also often have difficulty conceptualizing themselves in coherent and adaptive ways, so that self-other pathology is kind of a psychologically coherent construct. Does that make sense if I say it that way? Like that has its origins in psychodynamic theory, maybe obviously, but self-other conceptualization, like object relations, like the ability to think about yourself and other people in coherent and adaptive ways. That's criterion A in the AMPD. So yeah, the AMPD model I think handles it the way you just described. The HiTOP model isn't as explicit about that distinction because some of that interpersonal stuff is sitting along with the personality trait stuff, and that's an ongoing area of discussion and research, right? Like how much can you really separate out, let's call them criterion A, self, other problems from criterion B, more dispositional trait type problems? Can you really separate them out? I think that I can appreciate the distinction psychologically and clinically because it really has to do with like everybody has a personality and they're going to have quirks. But the criterion A stuff is like, okay, that's what we meant by personality disorders, right? There are serious issues with being able to conceptualize self and other in a coherent and adaptive way, which requires a very different therapeutic approach. Because those are people who aren't going to be able to form a therapeutic relationship as readily. And these kinds of things come to the fore, right, in terms of how you have to work with them clinically. So it's a bit complex, right, what I'm trying to describe there. And there's, different models out there in the literature. But I think, to get back again to your question, should we dispense with the idea of personality disorders versus other disorders? I think we need to recast maybe what that meant in the first place as, presentations. Like, so what I'm going to say is personality disorders are clinical presentations where self-other disturbance is very prominent in the clinical picture, right? There's a prominent aspect of dealing with this person where the clinician comes to realize that the person has, notable challenges in having a coherent sense of who they are, how they relate to other people, like coherent ideas about the motives of other people, good working mental models of self and other. Like if you don't have that stuff, then those are interpersonal kinds of problems that are going to manifest. And that's not relevant to every clinical case. When it is relevant, that's what we meant by the personality disorders in the first place, is what I think is going on, in the clinic, essentially.
In the HiTOP model, are there any threshold effects? So do you think about these what's the word I should use? Should I use the word symptoms, severity? Which should I use?
Do we think about the symptoms, maybe like the stuff the raw meat, like the stuff that people present?
Yeah. Do you think that the severity of that, is that a purely linear sort of, as it gets higher, it gets more challenging, or are there thresholds or cutoffs where it sort of seems like, okay, now this is where a person's really struggling, right? Sort of how we think about, sort of like what you were talking about earlier, when you hit the magic number of 5, then you have the disorder, but something more empirically based.
Yeah, no, that's a fantastic question. It's something I've thought about for many, many years and tried to work on. So I have some publications about this. So long story short, there are pretty sophisticated statistical approaches that can be taken to ask whether a collection of, let's call them symptoms, right, or criteria, or essential clinical features, symptoms probably works for this, right, whether those things are organized empirically in such a way that there is some discrete aspect to that distribution versus that it's smooth and continuous, right? So we've done things like this. Many other colleagues have done things like this, right? So there's a set of statistical tools that you can use. If you have a data set that contains a list of these symptoms on a group of people, to ask whether the distributions are continuous or discrete, or have discrete type features, right? Or are smooth and continuous in various ways. And that literature is pretty consistent in saying it's very rare to encounter non-smooth, discrete features. Does that make sense? Like that's rarely encountered in data. It's more typical to conclude from this model fitting exercise that things are continuous. So that's another basis for a scientific basis for the HiTOP approach. Now, that doesn't mean you can't set practical cutoffs, but they would be well understood as having a practical aspect to them, not a scientific aspect, if that makes sense. And that happens all the time in medicine. Like, that's not rare in medicine. There's lots of classic examples, right? Blood pressure is a classic example, right? There's a point at which that's a continuous variable, right? Your systolic and diastolic blood pressure are continuous variables. But as everybody knows from going to the doctor, they measure that continuously. But then there's a point where they're like, oh, you might have hypertension, right? And we might want to prescribe beta blockers or something like this, right? That's practical because the risk, right, for undesirable effects like a stroke are much enhanced at certain levels of this continuous variable of blood pressure. So it's meaningful to talk about hypertension based on having a certain level of blood pressure. That's clinically useful and meaningful. There's some thresholds there, but they're set on a practical basis. That no one's claiming that blood pressure has discrete features in its distribution. What's being said is that there's a certain level of blood pressure beyond which we know clinically that the risks of, really unpleasant things happening, like a stroke, are much enhanced. So I think that's the way to begin thinking about this in psychopathology. Like, the underlying symptom structures are pretty continuous. But for practical purposes, we can say, like, and we do this intuitively anyway, like, this is the level of depression where the person can't do stuff they really want to be doing, like going to work or school. There are levels, right? And that's where the social impact occurs. That's a practical distinction, not a scientific one, which doesn't mean we can't make a distinction. Just recognize depression is continuous. But there's a level, right, beyond which it really does require some kind of intervention because the person's not functioning.
So then it would be reasonable to say that it's so if we were using depression or whatever, that its association with various outcomes would be nonlinear, that like above certain thresholds is when we would see that, just the example you gave, right? Difficulty at work. And if we said, unemployment or losing a job or whatever, that there are at the, whatever we're saying are the lower levels, the odds of that happening are because of the depression are somewhere, very minimal. Then you hit a certain threshold, now it starts to be that, it starts to become like, all right, sometimes people do have trouble at work because of this. Then you hit a higher level, then this is often people have trouble at work because of this.
Yeah, and that's likely to be pretty smooth and continuous too, right? So people have studied that as well. Basically, this is the regression, right? Like the statistical relationship between the predictor and the outcome, where the predictor is psychopathology symptom, amount, and the outcome is something like, ability to work. You rarely see that has some kind of like nonlinear aspect to it. So people have tried to study that too, and that looks pretty continuous. So again, like, there's a practical place to set it, even if the data are pretty continuous, because there's there's the probability of really not being able to function is a linear function of how many symptoms. Well, I mean, like we can admit that that's continuous. That's fine, and we can say, like, okay, as a field, like, we get together and say that, practice guidelines are such that this level, is the place at which the undesirable effects become more likely than not. Like, we could do it that way, right? Greater than 50%, right? Again, that's somewhat arbitrary, but also practically useful. That's the point I guess I'm trying to convey. Even if everything is smooth and continuous, there are practical aspects. And that's the basis we could use to set thresholds, and just say, like, it's set there for practical reasons. The science is that it's smooth and continuous, but this is the point where the clinician should really start paying attention, because the probability of adverse events is greater than it was at a level below that, enough so that really that's where you pay attention. And the other point I guess I could convey is that this is always in clinical settings. People, again, do this intuitively, a kind of a triaging kind of thing that people do. Mm-hmm. Right. So, like, I spent a lot of time in my training in drug and alcohol type settings. It's always like this, by which I mean, like, okay, the person has some difficulties and good social supports, and there's no real medical complications of like alcohol dependence, right? You might be able to do, outpatient approaches to detox that could be kind of effective. Okay, the presentation is more severe than that, and they've managed to, really like lose their social supports. Well, then maybe a partial hospitalization kind of approach is okay. Like, and there's no medical complications, right? Like, let's say you have that kind of presentation, but there's not good social supports. It's kind of a medium level of severity, right? Well, then like partial hospital, maybe that's the way to go. Okay, and then at the extreme, right? This person has no social supports. They've been drinking heavily for years. Maybe there's some initial signs of Wernicke-Korsakoff. They might have peripheral neuropathy. I mean, you got to start them on vitamin supplements immediately, and you might want to detox them in an inpatient way because there's possible medical complications that could be really severe. That's inpatient. You see what I'm saying? Like, there's a continuum. There's a continuum intervention intensity that corresponds fairly naturally to a continuum of symptom presentation. And that's how it works anyway, right? Like that. No, it would be weird to think about like, okay, our alcohol dependence treatment unit either treats people or doesn't, right? Like, as is implied by a diagnosis, right? Like, you either make criteria for alcohol dependence and we throw the kitchen sink at you and you're inpatient for a month, or we send you home. Nobody does this, right? Like, that's not how these things work. Practically speaking, there's a graded degree of intervention intensity, right, that corresponds with a graded degree of symptom presentation and severity and associated effects of the problem. So, I mean, I think really like getting back to the point of this whole discussion, like the HiTOP kind of thing is like, okay, we know this. Let's not pretend that there's a bunch of categories where we know there aren't. Let's try to develop more scientifically based approaches that link naturally to these practical things we can do to be effective clinically, which often have a graded intensity aspect to them, just naturally.
So on the HiTOP website, which I'll link to, there are several measures that have been developed to assess disorder psychopathology based on the HiTOP model. If you were talking to a clinician who said, hey, could you point me in the direction of one or two tools because I want to try this in practice or see how this works with a client, what would be the one or two tools you would point them towards?
Yeah, so HiTOP now has some assessment measures that are available that are, I think, connected on the website. So that might be one tool, right? You could use the HiTOP assessment. I think it's called the HiTOP SR. Kind of try to use that, try to interpret that clinically, see if that gives you something useful. And also we have a clinician network that's developed, right, that should be linked up there on the website. Join the clinician network. Connect with and network with other people trying to do this stuff, in applied ways.
And so I think it's helpful, with the HiTOP SR, whatever that tool is.
Yeah.
And I'll link this as well. So and tell me if I'm wrong, what the clinician gets is they get, and you used this word earlier, they get this profile where there'll be these, 3 or so general categories. And then underneath of each one of those are a bunch of sort of subcategories. And then you get this, it reminded me of an MMPI profile is what it reminded me of, where you get this score, right, on each of these sub-factors. And so you can see by looking across this client's profile, sort of at the higher level factors where maybe there are some elevations. So if it's, for example, if they have a whole bunch of scores that are high on externalizing and low on internalizing, you can start to immediately say, oh, okay, this person's more of an externalizer than an internalizer, right? So that gives you clinical information. But then there's also these sub-factors underneath of that would be terms that most of us would probably be more used to seeing in the DSM, like subcategories within the DSM, where you're going to see those elevations or not on that profile.
Yeah. Yeah, that's the kind of information that is conveyed by that. And the hope is that that's more clinically useful than just diagnosis present absent. So that's a way to kind of engage directly with the model in a clinical setting.
Right. So one of the things, and we were talking about it earlier about this consortium, and one of the things that I thought was very cool that I'd love for you to talk a little bit about is, so you guys kind of created a bunch of rules, for lack of a better term, about how we're going to move forward with this thing. And part of that is for folks who want to propose changes to the HiTOP model. So I was wondering
Oh,
if you could talk about that process a little bit.
yeah, no, I mean, so that's something that many high toppers, should we call them high toppers? I said this popped into my head. Let's call them high toppers. The members of the consortium, right, are pretty invested in.
Wait, did you just come up with that?
It just popped into my head.
I think it needs to stick. I think that's kind of, I think that you guys need like t-shirts or pins or mugs or something. I'm a high topper. I love a high topper, you know.
Yeah, we have a high top society now, which is linked to on the webpage. And at our most recent society meeting, we had our first, like swag, right? Like, so I have a high top chip clip now, right? So you're official as a society once you have a chip clip, as I think everybody, right? So that's kind of fun, yeah. And t-shirts would be good. So yeah, there's a high top society too, right? Like there's the consortium, which is the scientific kind of branch of high top, but there's a society too that people can belong to and pay dues to and come to our meetings. We have yearly meetings. So that's on the webpage too. That's another way to engage with the high top enterprise, right? Join the society, get the society newsletter, come to the meetings, present your work, connect with people at a conference. That's a good way to engage with the group. And then what were we talking about?
So the process of proposing changes to the high top model.
Yeah, so there's a revisions group. My colleague Mary Forbes, who's at Macquarie in Australia, leads that group, and they, put together a paper describing a systematic approach to proposing changes. So there's a template for proposing changes, like a way of assembling the evidence that then that committee would consider, right? If you said we should change something about the model, like the name of something or where it's located or whatever. Yeah, there's a process for engaging with the model that way. So yeah, that is a thing that the consortium has attempted to develop, because that's always a challenge with these things, right? Like these models can become readily ossified, like kind of fixed in place, kind of stuck, right? Certainly that's an issue with the DSM, as we've been discussing. Like that can kind of get stuck because there's various political forces and practical reasons to not mess with it. So HiTOP could suffer the same fate, of course. So there's been some sensitivity to trying to have a dynamic process where it's not changing at random, right, or based on the whims of a few people, but a systematic process for proposing changes and for that to be considered by the committee that handles, revisions. So it's the revisions work group that handles this.
Yeah, it struck me, it sort of looking at it and seeing that revision and I think there's a paper that you all have written that sort of specifies how that goes. But it just really struck me again that like you're not part of like the infrastructure of some pre-existing organization where this sort of thing would be, sort of like how the American Psychiatric Association has with, that but you developed sort of these rigorous set of standards and expectations for folks to propose changes to the model. It's just struck me as impressive and really thoughtful. And again, I don't think you have any full-time staff that are working. I mean, it's just sort of a lot of effort.
It is. That's Mary Forbes for you, right? Like she was the person who really directed that and led it. So she's the person who felt that was important and kind of led the effort to pull that together. I think along with Aidan Wright was part of that too, as part of the revisions work group, one of the co-chairs. But yeah, it's a good thing that you're alluding to, which is that there have been a lot of selfless people involved, devoting a lot of time and effort to the endeavor, I guess because they believe in what it's about. So yeah, that's been gratifying, again, like it's the word I used before. That's how that feels to me. It's like it's cool that colleagues are like, we want to engage with this and contribute to it. So that's been great to see.
So I'm wondering if you could talk just a little bit more, and you sort of started to earlier, about what this would look like, or where you all are thinking about going with this clinically. We have this, if nothing else, large literature on, whether they're randomized control trials or other sorts of trials looking at specific treatments for specific problems, and that's organized in all sorts of different ways. Right? But we have decades of work looking at this based on the existing DSM classification. And now we have this
Yeah,
new model.
right. So again, there's a clinical applications work group within HiTOP that's published some papers about this. So that's one place to go for some resources for how you might apply this clinically. And I think, the basic scheme is that there are many, many psychotherapies out there in the world that wax and wane in their popularity and so on, and many sort of therapeutic techniques. And the idea, I think, ultimately would be to tether specific techniques and approaches to specific HiTOP presentations, which I think is, again, like intuitively what a lot of clinicians do. It's kind of rare to encounter somebody who's very ideologically committed to a particular like 3-letter therapy, right? Like all I do is DBT. That would be kind of odd, right? It's more like you have an armamentarium of different approaches and you can pull them out as you need to work effectively with different aspects of a person's presentation, maybe even shifting midway through because something changes in the presentation or relationship, right? So I think that people do that relatively intuitively, and maybe what HiTOP can contribute is a more systematic kind of like flowchart kind of approach or something like this, right? Like here are some approaches that correspond with these kinds of things. And another thing, this is not directly related to HiTOP, but that I've been kind of working on. There's this clinic that we have called the ARCS Institute, and I can give you the URL for that, but it's ARCS Institute. And that's a research and training clinic that I'm connected with here in Minnesota, where the goal is really kind of to develop these approaches clinically. So that's an existing, clinic, right? Like there's a group of clinicians who are part of this group practice who are also trying to implement these approaches clinically. The ARCS Institute is all about trying to do this systematically. So that's something I'm personally involved in that isn't directly connected with the HiTOP consortium, which is more of an academic endeavor. But ARCS came about because the idea was, could we create, a group practice here in Minnesota in which, we really try to take these ideas that are percolating in the academic literature and apply them clinically. And so all the clinicians that are connected with ARCS are trying to take this kind of approach. And we have, a group, kind of group supervision thing. We have trainees, right, like practicum students who are connected with it. And that's the goal, right, to really kind of lay this stuff out clinically and try to apply it, working with a diverse set of clients who are connected with that practice. So that's been really great. Like that really is a very translational endeavor for me that I've enjoyed getting involved with, where we're really trying to see if we can make this work clinically. And so we do a lot of personality profiling, right, as part of how we try to conduct our work. And again, the clinicians we spend at least an hour a week in kind of a, like a group supervision kind of setting, talking about how's this going? How is this applied with this particular case? And what are we learning from this approach? How can we tweak it? And so it's something we're trying to develop. And we're trying to develop things like a more formalized treatment manual type of approach, beginning to produce some materials like that, right? Getting some papers together and maybe trying to come up with something that looks more like a treatment manual, really. And we're calling that kind of personality-driven psychotherapy. Because really, again, in my way of thinking, personality is the center of all of this, and that's what connects HiTOP, the AMPD model, with a lot of stuff that I've done academically. So yeah, that's a specific group practice. So if there are people listening who want to, seek help, right, and the reimbursement stuff works out correctly in terms of where we're licensed and all of those practical things, but that's a way to connect with this approach if it seems like it's something you're interested in as a client. Or as a practitioner, if you want to connect with us, that's a way to do that too. So again, in the academic realm, there's HiTOP per se and its clinical work group. And then in my, sort of professional life, my specific professional life, I'm connected with this ARCS Institute clinic where I'm, I guess serving as the scientific director and trying to have people working for us, right? Like full-time clinicians and people like that who are really invested in this approach and trying to use it clinically. So those are two things that are separate, right? That I'm involved with that might be of interest to your listeners.
So how do you even begin to move forward with the idea of developing protocols, treatment protocols, broadly defined, for this profile, right? Like I think you and I and many people are very much on the same page that the idea of this treatment for this DSM category for this problem is flawed. So we can just sort of say that is true. And even though fatally flawed often, uh, the way one thinks about it is, I don't want to say straightforward, because for those listening who have been involved in treatment, intervention studies, RCTs, it's not straightforward. But
Yeah.
the idea of this treatment for this problem, right? We have a treatment group and a placebo group, or treatment group, some sort of control, whatever, is like at least relatively ish straightforward, at least at the broad level, right? A person get their head wrapped around that.
Yeah.
Where if I'm thinking about this profile, then it's like, man, that's not that's not even on a single dimension. I mean, that is so complex. So how do I even begin to think about a treatment for a profile and an attempt to standardize it?
Yeah. No, a great question. It's something we're struggling with, right? I think my intuition about this, right, is that there's just a lot of stuff out there that we all learn how to do. And it's about being systematic about connecting different kinds of presentations within, kind of the personality and symptom profile with different techniques and approaches we have available. So I can try to be concrete about it, right? Like when people are kind of antagonistic or disengaged, or they don't really, they aren't really maybe ready for, like, think of it in a stages of change kind of way. They aren't really ready. That's why people have developed things like motivational interviewing.
Sure.
Right. That's the reason that kind of, therapeutic approach has been articulated. So then, right, if that's in the profile, well, you turn to those kinds of approaches and tools. So that's the essence of, I think, what we're trying to articulate within the ARCS Institute is, okay, it's not that you need like whole new, like another 3-letter psychotherapy. Like, I don't know if we need that, except in the sense that we made up a 3-letter. We made a PD because you just have
right.
to.
It's the law. I'm pretty sure it's the law.
Yeah. It's the law that you need a 3-letter acronym, right? Like,
yeah.
So PDT, but like what that is let's pay attention to personality as the framework, and let's bring in psychotherapeutic approaches that have been well articulated and tested. Because our kind of through our lens, right, what those things are doing is they're tapping into different aspects of the symptom and personality profile and coming up with techniques and strategies that are kind of key to different aspects of it. But we could be systematic about that. We could say like, oh, if this is present, right, try these things, right? And it gets a little tricky because you can't do the whole thing at once, which is, I think, what you're alluding to. Like, you got to kind of pick and choose which things to focus on. But that's a collaborative discussion with the patient in the context of a therapeutic assessment. Does that make sense if I say it that way? So there is a literature on therapeutic assessment, which I admire, right? Where the idea is to really use assessment, because not a lot of people are using formal psychometric assessments in the way that I would like to. Because I find that super useful in the clinic. So like the idea is we're going to do this collaboratively, right? It's not just for, like some custody battle thing where you have to take the MMPI or whatever, right? It's you're going to complete this questionnaire and we're going to interpret it together. Like, this is what your questionnaire shows. Here's how your scores compare to, norms. And let's talk about what you were trying to explain to me, you, the client, by completing my questionnaire. Let's talk through what your personality profile means about you and kind of your thoughts and my thoughts about how we can, prioritize, right? So there's a therapeutic assessment aspect to this too, not just here's your profile, but rather like, here's what your profile suggests to me as, like the treating professional. Tell me about, what's that like in your life, right? How these traits show up, like, does this seem consistent with your sense of yourself, or have you learned something new about yourself here? And can we work together to prioritize around this? Like, what areas are really concerning to you, right? Is it the perfectionism? Is it the current depressivity? right? Like, is it that you said that you're kind of a manipulative person and that's kind of interfering with your relationships, right? Like you have all this personality data if you do it this way, and you just try to talk with the person about how this stuff shows up in their lives and how we, as a therapeutic team, like me and the client, want to kind of prioritize, right, among those things. So that's kind of the essence of it. And then what do you do therapeutically? It's like you pull out the armamentarium of stuff that's connected with the areas that you and the client agree are areas of initial focus.
And part of the idea here too is that there are symptom clusters. Again, I'm going to use DSM language. I apologize. I just don't have other language. But there are symptoms that are going to tend to cluster together. In other words, there are certain symptoms challenges that people are going to have that are going to correlate with other ones, that they're typically elevated together or sort of pushed down together. And so you would start to see these, I would imagine you would start to see these groupings of things so that they're going to be related, so that you're going to attack aspects of that person's life, personality, whatever, that could potentially push all of them down or a bunch of them down simultaneously.
Yeah. Yeah. And you're looking for like points of entry too. And that's why the conversation with the client is so important, because they've got to recognize that it's something they really want to work on, or it's going to be harder. Of course, that's, again, like when this works well, a conversation, right? It's not like you impose stuff on the case. It's rather you try to collaboratively do the assessment with the client and have the assessment data delivery back to the client, hopefully have therapeutic aspects to it, because they're learning something about themselves in that process. And then you kind of try to work together to decide this is where you want to focus at least your initial efforts, because these are the tendencies that are currently the most problematic for you, the client.
I'm thinking, as I was preparing for this and I was looking at the sort of the primary figure that's everywhere regarding the HiTOP, which I'll link, there's a lot going on in that figure. And it can be a little bit overwhelming, trying to get your head wrapped around all of it. But as you're talking, particularly clinically, but even in your discussion about this initially, so the last person I talked to a couple of weeks ago for the podcast was Del Paulus, so dark tetrad. And so one of the things he said, and I'm going to get this wrong, but one of the things he said was something like, finding the level of the construct or sort of the sub-levels that are of value, and not sort of breaking apart more than that, and not sort of clustering together, sort of putting together higher than that. So for him it was these dark personality traits, and so he said sort of these 4 dark personality traits. That's where he sort of sits, where potentially you could break it down more than that, break those factors into sub factors, but people have done, but it doesn't really seem to add very much, right? Or he said, there are people who are looking at this sort of D factor, or sort of the dark factor. And he said, that's not, to me, that's not very interesting either, because, and he gave, psychometric reasons as well as conceptual reasons as well, or practical reasons as well. And I'm thinking about that as you're talking, because like you have this model, which empirically and in theoretically, you have all these different levels. But what I'm hearing you sort of say is, there is all this stuff that's great, and I'm going to continue to look at it even, but practically, let's figure out sort of the levels that make sense for this patient, or patients in general, but this patient and treatment, and let's use that. We don't have to use all of it. Let's just figure out what's helpful clinically right now.
Yeah, and it's pretty rare to have everything all there. Not, I mean, like a lot of people have a lot of different kinds of problems, right? But at least in our experience at the Arcs Institute of trying to kind of roll out this approach, people often have like a presenting complaint or current set of concerns thing that helps with this prioritization issue, even if their lives and their personality profiles are complicated, if that makes sense. And sometimes there's like a way of saying it's this mix, right? Like it's this particular mix of things, because they're like our push and pull elements to different traits in people often. right? Like they might be very attention seeking, like they really want attention, but in addition to that, they're sort of I don't know, like shy and inhibited, something like this is a potential combination you could see. So like it's in the combination that you kind of reach the formulation and help to reach an understanding with the client, and that's kind of how you focus it. So it seems complicated because there's lots of elements to people's personalities, but within a particular person, right, it often has this coherence because that's how personality works in a person. But in a person, it's that mix of traits. In the population, it's a variety of different dimensions, and so it's complicated at the population level. But within a person, that's who they are. They're this mix of things. So yeah, I think that's where you're, sort of driving at as the assessor and as the therapist. You're trying to get a integrated understanding of the person from the profile and help to convey it to them. And then that's kind of like what you work on. And yeah, that often, practically speaking, has what I want to call them like push and pull elements, right? Like you want these things, but these traits interfere with getting them, right? You'd like these things to happen to you, but you have trouble connecting with other people, right? And you want intimacy, but you are scared of it, like things like that. Formulations along those lines are often sitting in the combination of traits.
So one of the things I always ask everyone at the end of the conversation is if they've had, or what specific pushback that they've had toward their work.
Yeah. Well, my work, right? Like, so if we want to conceptualize that as, the work on HiTOP, specifically, I think, the pushback is understandable and kind of comes from parts of the academic firmament, right, where there's a lot of investment in pre-existing categorical notions, right? If you've spent your whole career, right, focused around some specific category, well, then if I'm saying something like, that's kind of part of a bigger picture, and we really shouldn't like devote ourselves to these categories in quite that way because patient presentations are more complicated. These things aren't really categories of nature. Well, that's a challenge, right, to your whole worldview because you've become the expert on categorical disorder X, right? You're known the world over as like the ADHD expert, like, or whatever it is. And your whole career and professional identity are tied to these category labels. So to the extent that there's pushback, I think that's a place that it comes from. And I think it's totally understandable. Right? I've been fortunate that I've been able to build a career around the alternative to that, right? Kind of the HiTOP style approach. But now I'm known as the dimensions guy or whatever, right? Or the HiTOP founder guy or things like this, right? Like, so like that's my identity. So I don't have this problem of having been a conduct disorder researcher or whatever, right? Who now takes a different approach where I've got to somehow slough off the old identity to become connected with the multidimensional HiTOP style approach. Rather, I'm the person who has been pretty consistent throughout my career and my writings in providing this alternative, right? So, but I totally get it, right? If you're the ADHD expert, the schizophrenia expert, right? The eating disorders expert, it's going to be a challenge, right? Just sort of personally and professionally to cope with the HiTOP alternative. So I think that's often where the pushback comes from, and it's easy to understand. And then like, how do you deal with that if you're that person? Well, we've seen people make these shifts, right? I've seen people do this and say like, that's a really good point. Like I'm trying to understand alcohol dependence or whatever, but I might be able to do a better job understanding if I think about it in this more multidimensional way. And that's when I think the shift has happened. It's when even if you have a prior investment in a particular area, it's like we're saying those areas don't exist. That would be absurd. Nobody's saying like there aren't people with alcohol dependence. It's rather recasting it within this multidimensional framework. And I think that if you can make that shift, then you become a little less antagonistic toward the enterprise. But yeah, to the extent that I've seen pushback, it's about investment in existing categorical concepts and how that's tied up in people's professional identities. And again, I want to be very sympathetic to that because I get it, right? People have invested years of their lives and careers in these concepts. So if we're going to move to a more, multidimensional and hopefully scientifically based approach, we have to be sensitive to how those shifts can happen in a way that recognizes those previous contributions and doesn't, take on language like that was all dumb to begin with. Because I don't think that's even true, right? That was the best we could do in the era. And many very good and useful things have been done under the umbrellas of those categorical concepts. So we got to recognize those contributions and now move forward with that as the edifice of what we're trying to do. Mm-hmm. So that language, that kind of diplomacy is, I think, critical to the endeavor.
Yeah, it makes, as you were talking, I was thinking that, I was thinking sort of from like a Kuhnian, like paradigmatic shift, the idea of like a better ideas basically replacing worse ideas, without getting into it too much. But then sort of from what I understand, the actual data on it is in science, it's not just better ideas don't just knock out worse ideas. It also has to do with the people who have the, I'm using the word worse and I'm being mindful of that's awfully critical, but that it has to do with folks who sort of ascribe to those older ideas that aren't as empirically justifiable. It has to like them leaving the field eventually, retiring and that sort of thing, that these sort of paradigmatic shifts happen more on that timeline than just on the idea timeline.
Yeah.
And
that's fair. I mean, obviously that dynamic is salient, right? And that's why generativity is so important, right? Like I want to call that out too, because I think that's the thing I believe deeply in everything I try to do, right? Like the junior people are the future. Mm-hmm. If you can win their hearts and minds, and hopefully, like if I win their hearts and minds, I don't mean in some sort of manipulative way, but like based on the evidence, right? Mm-hmm. That this will work better for what they're trying to achieve professionally. Then you have generativity, right? And you have the ability to shift the field in a direction because they're the engine, right, of what's going to happen next. So yeah, I think that's another way that I think about it, right? That's, I think, hopefully a positive spin on the Kuhnian paradigm shift way of thinking about it. It's not just that like the older generation retires, mm-hmm. right? It's that the younger generation becomes connected with a novel set of ideas because they're moving the field in a direction that they believe in. So,
right, yeah, and I think that was absolutely right. And sort of the idea is that these newer, more, but both right, both in the factor analyses, but also in the consulting room, right? Like both of those things are pointing to, oh yeah, this makes more sense. That people who are coming up or people like me who aren't invested in the old school model, I'm easily swayed by data and, experience. Then that happens. And then, that will start to sort of slowly take over. So the last thing before I let you go. So we got several resources that I will link in the show notes. Are there anything else, any other resources or links or whatever? I think did you guys either you just have or just had a book come out, but other things you want me to link that you want people to know about who are interested in this?
Yeah, I mentioned the ARCS Institute, right? Mm-hmm. The clinic I'm connected with here, the clinical practice. I can give you the ARCS Institute URL. I could just email that to you for the show notes. That's one thing that might be helpful to people. Mm-hmm. That occurs to me in that context. HiTOP stuff, I think you pretty much have those links. But of course, I'm happy to look over what you want to post and consult about it.
Okay, yeah, and if there's anything else, I just want to make sure to be able to, because I'm sure there'll be lots of people who are listening who want to learn more, to give them resources.
Great, yeah, for sure.
Bob, this has been fantastic. I can't tell you how much I appreciate it.
Well, I appreciate the opportunity, right? It's fun for me to try to formulate my thoughts about all of this in a podcast kind of format. So I appreciate your time and inviting me to participate.
Oh, are you kidding? It's my pleasure. Thanks so much for watching. If you found it helpful, please like the video and subscribe to the channel. I'll see you in the next video where we continue exploring the science of psychotherapy and applied psychology.